Hi, everybody. You are listening to the Medea podcast series. Medea Medical Education Academy is a global medical education provider dedicated to designing, delivering, and evaluating medical education programs worldwide. Our podcast series wants to bring to you a new way of delivering medical education, allowing to gain knowledge in an easy and accessible way, ideal for continuing medical education. In this episode, we have two important experts, Jérôme Chambost and Carlo Alviggi, who are going to talk about AI and reproductive health. This is an introduction to the upcoming continuing medical education program, Medical Assisted Reproduction Prediction Tools, KPIs, Biological Factors, RWE, and Clinical Decisions, which will take place on May 10th at 1 p.m. Central European Summer Time.
Hello, everyone. It's a great pleasure for me to be here today. And this is, I think, a nice opportunity for discussing an intriguing topic, which is the role of artificial intelligence in medicine in general, but in particular in the field of reproductive medicine and assisted reproductive technologies. First of all, let me introduce myself. My name is Carlo Alviggi, and I work in the south of Italy, in Naples University Federico II. And my field of interest in both research and clinical practice is in vitro fertilization, and in particular, ovarian stimulation and fertility preservation. It's a great pleasure for me to introduce Jérôme, and let me tell you, it's a nice opportunity for all of us to discuss with him a so important topic nowadays. So Jérôme, tell us something about you, and then we will go straight to this nice and intriguing discussion.
Thank you very much, Carlo. It's a pleasure for me as well to be here and to discuss those important topics. So I am Jérôme. I'm a Chief Technology Officer and Head of Artificial Intelligence at Apricity, which is a fertility service company in the UK. So I'm a data scientist in training, and I have been working in artificial intelligence and data science projects for the past 7 years, applied to medicine, and for the past 4 years, specifically on projects dedicated to reproductive medicine and fertility. And it's a pleasure to be here and to discuss those topics.
Thank you. So, Jérôme, I have a curiosity, something I think about so many times, and I would like to know your opinion, because we do different things in the daily life. And I would like to start with the research. I will talk about reproductive medicine and embryology, but I think that we could extend what we are going to say to several fields of medicine. So in the last 20 years, we had the era of evidence-based medicine. And so we respect this. I think that it was an incredible opportunity for standardizing observation and for having clean data. But the problem is that sometimes, according to classical approach of randomized controlled trials, we run the risk of having a picture of a specific categories of patients that don't reflect daily clinical practice. We identify an endpoint, we do a simple sites analysis, and for managing confounders and biases, what we do, we use very restricted inclusion and exclusion criteria. So we have an ideal population with not confounders, and even if we reach the sample size, we run the risk to have an information that we can apply specifically on that population. In the last year, something changed, because now the era of big data analysis is there, meaning that, please correct me if I say something which is not perfectly consistent with the reality, but in so many fields of medicine, there is the possibility of having continuous input of data, having an incredible quantity of information. So even if you analyze this data with a retrospective approach, the sample size is so huge to allow management of confounders and even biases. But what I think that in terms of machine learning, this is an incredible opportunity for having progressive information and for have more precise strategies of intervention. But, and I'm going to conclude my reflections and question, but scientific community is so related to classical evidence-based approach and randomized controlled trials. They are resistant to the idea of this changing. And probably they're right. I don't know. So do you think, that's the question, that in the next future, big data analysis and real world data approach can substitute classical approach of randomized controlled trials and have a specific and important role in the ranking of evidence-based medicine?
So thanks, Carlos. This is a very interesting question. I would say that I don't think that real world evidence will substitute the randomized clinical trials. I think that randomized clinical trials will always be the king methodology to make sure that we erase all the confounders. But as you say, this is very difficult in healthcare and specifically in this field of reproductive medicine where we have really small samples and plenty of things to consider. I would say that artificial intelligence will not substitute, but will be in great support. So it's not one or the other. It's for sure, as you mentioned, we now have, and we will have even more, access to huge data sets of retrospective treatments and for better comprehension of what happened for subsets, specific subsets of patients all over the world, if and only if we have this right and clean and accurate data. And I would say that, like you said, there was a revolution for the past years about the algorithms. So our capability of classifying, of predicting outcomes or predicting recommendation based on data. So the algorithms exist. What we are currently lacking, and we're filling in the gap at the moment, is this clean data. As we say in machine learning, it's like garbage in, garbage out. So if you look at all the EMRs in the field, in every country, every clinic, there is a huge effort that is being done, but that's not completely finalized about really understanding, having structured data that describe the whole treatment from A to Z, and that will be able to input in algorithms. Second part, so when I say clean and accurate, is also standardized. That when you look at the data sets of 3 different clinics, they will likely be not homogeneous and very different. And this is a big complexity for machine learning algorithm to make sense and to reclean this data before actually being able to combine it and to make assumption recommendation based on this input. And thirdly, you mentioned the revolution. There was one last year actually, and that we're starting to get the grip on at this very moment, is the revolution about generate artificial intelligence and large language models. This is an opportunity to actually use unstructured data much better and to spend much less time like structuring all the data that we have and gain enormous time to feed the models that we already had in the past, the machine learning predictive models.
I perfectly agree. And if I can try to take the two or three take-home messages. So please tell me if I'm right. First, we cannot hypothesize that this approach will substitute, but can be perfect in terms of integration with the classical randomized control trial. Matching information from the two sources can probably provide the best quality data in the future. Secondly, I think you mentioned something that is very important even by educational point of view, because my angle is the angle of someone teaching that has the responsibility of education of new generation of people involved in research. So in the past, limits of retrospective analysis was related to two things. The first, we didn't have a machine learning system. And the second, which is in my opinion the most important, the quality of retrospective data was very low. So it was impossible to have something robust that could provide information. I think that if we teach in the university, we have to create a culture. Anytime we have new people to educate, new people that are involved in research or they want to be part of research for a given time, we need to create, to propose, and to teach a very accurate way of data input, meaning that you know that if we go into clinical practice, for instance, Let's think about follicle count. We count the follicles before starting stimulation. It is very subjective. And let me tell you what happens in the field of reproductive medicine. In a reproductive medicine community, the physician sometimes have to be very fast and practical. So in 2 minutes, we understand how many follicles are there and what we have to do for stimulating the patient. If we have to acquire, if we have to count follicles, to specify the sites, put the information in a data set, it takes time, and we run the risk of not having accurate evaluation.
Exactly.
I think that we have to find a way for educating ourselves and even fellows to spend a little bit more time for having accurate data input and managing the problem of interreliability. We have to find ways to move from subjective to objective. And even machines are very important because, for instance, three-dimensional follicle count, I'm just talking about the example I mentioned, probably can make things faster. But the take-home message from what you said could be that on my side, from teaching point of view, but even from researcher point of view, is to spend time in accurate data input. Because if I understood well, prospective, accurate input of data makes retrospective analysis robust, reliable, and useful for the development of algorithms and machine learning.
Exactly correct. And the opposite is true, is that if you have 100,000 cycles of retrospective data with bad data, you're going to struggle a lot to make any sense of it. There's two topics, it's quantity, but also quality of data. And so, yes, as a teacher, we need to educate everybody for the importance of good quality data, but you're not alone. I think this is a common effort also for the tools and the systems providers to accompany the clinicians. And we're also on this topic to support the clinicians in having like integrations and the least manual entry possible from humans. Because yes, we need to spend more time on making sure that the data is accurate is fine, but actually the best way to do that is that you don't do it, that the systems, your ultra sonographer system communicates directly with your AMR and with your database, that your prescription tools enter directly the dosage in your EMRs and you have no possibility for errors. So yeah, for me, this is a common effort, systems providers and clinicians to spend time on that.
That's great. I was thinking about something that's probably stupid, but I like to share. When I started reproductive medicine, I remember that obviously you had to express technical skills. We had few drugs, few combination, not so many protocols. And what was very important was fully understanding the way the hypothalamus pituitary ovarian axis works, to have information and experience in reproductive endocrinology and whatever. And so any single case was something to think about. Now, with some initial, probably, expressions of artificial intelligence, we are going to develop algorithms that give the protocol, the starting dose. Everything is on the application. I think that neuronal geometry is developed in any single mind according to the use. Because if you have everything with your click in few seconds, you run the risk of having a new generation of reproductive doctors that will just apply algorithms. So it's a provocation, but do you think that this is for every field? Tomorrow we can have soldiers in reproductive medicine to say we are reproductive doctors, but is it sufficient to apply an algorithm to find the drug, find the starting dose, to find the changing of doses, to find the timing of triggering? Everything is on the application. So don't we run the risk of neuronal atrophy of this? It's just provocation, but
yeah, no, it's a good point. And actually, I don't have the same answer as 2 years ago. 2 years ago, I would answer definitely not. And all the experts agreed with me that the artificial intelligence would be in support to the clinician, and I'll detail more. Now, start seeing experts disagreeing with the revolution we had last year. I personally still believe that artificial intelligence and algorithms should be a tool that the doctors, the clinicians use to be more efficient and to spend more value time on complex cases. The way I see it is 70% of the cases of treatment could be considered a bit as a routine and that will be able to be identified, spotted, and with a treatment recommendation that is automatic and validated by a doctor. But where it's really important is also to identify the 30% of cases that are a bit more difficult, where you're going to need to spend more time on, that you're going to need to get more data on to take the best decisions and work in combination with algorithms. And like you say, I think, and I understand that this is provocative, but I don't think this will happen. I don't see the algorithms completely replacing or even like mostly replacing the doctor opinion and recommendation.
So I'm very happy about your reply because it's symmetric with the ones that you gave about the research. So even in this case, the algorithm have to be, the interpretation is important, it's a tool, and we don't have to think about it as the idea that they can substitute, because it's like automatic driving. So you can have an automatic system, but if you are not experienced, you cannot manage difficult situation or not predictable events. So I agree with you. The future is the perfect integration. Machine learning and predictive algorithm have to be integrated with a historical evidence-based approach. And in the clinical practice, this kind of tools has to be utilized as additional value that can improve our capability of taking decisions. But anyway, we have to take decisions anyway. And I don't know if you want to comment or want to ask me something about what happens in the reproductive medicine field.
Yes, as a clinician, I would like to know what's your current usage and what you feel about like your future usage about AI as a clinician and from a scientific perspective.
That's a very important point, because I want to tell you something that is strictly related to my direct experience, but I want to comment about what I'm seeing in the world now. For instance, inside the community that we call Poseidon, it's a community, it's a scientific group that tried to develop tools for personalizing ovarian stimulation. And inside this community, with the great support by Sandra Steves and all the group, a very nice algorithm has been developed, which is called ART calculator. This calculator is able to identify the number of oocytes we need for any given patient for having at least one euploid blood. And I don't want to give too many details because we don't have time, but the problem is that at any given age, we have an expected rate of aneuploidies. So the rate of aneuploidies in the embryos increases above 35 years of age in a very predictable way. And so just to give you an idea, probably 10 oocytes can be sufficient in a patient 35 years of age, but not in a patient 39 years of age, where probably 20, 25 eggs are required. But this algorithm is also based on the prediction of the outcome of all the steps during the procedure. Because if you have 10 oocytes, but you don't know which is the expected fertilization rate, which is the expected rate of blastulation, you cannot adapt the prediction. So you can put different kinds of information inside. You can use data from literature, or you can put inside data from your center. So the information, the prediction of the number of eggs is corrected according to the expected outcome of any single step until the development of blastocyst. Let me tell you what is my experience. This is something that started a few years ago. The number of observation is growing, but at the moment we are probably far from a robust algorithm worldwide. But you can tell me if I'm right. Machine learning is something that needs incredible numbers to have a significant increase of prediction capability. But let me tell you, it was an incredible tool of counseling with the patients because with this kind of, we can say artificial intelligence, probably is too much, but with this kind of approach, with this kind of algorithm, we can create an incredible alliance with the patient because we set the patient with the common aim we have with them. So we need to have in your single case, the ideal number of sites is 15. So let's talk or 20 or 10. So your ovarian reserve is not consistent with this number. So what we can do for reaching this number, we need to accumulate oocytes in different stimulation cycles. So it's something that we put in the middle and we can discuss about all together for having common aims. This is my personal experience in this field. There is another thing which is general, which is, I think, the only one that at this moment probably is promising, but probably I need to have more information about worldwide experiences, is the time-lapse technologies in embryo culture. I think that is the best example of how accumulating information about kinetics of embryo development, we can have integration in artificial intelligence system for one aim, which is embryo prioritization. We can put together different kind of informations, diploidy, kinetics, and so many independent variables that can probably help us to understand which embryo has to be transferred as a first. This is what I can say at the moment on clinical practice. Probably you know more about what's going on worldwide.
Yeah, I agree with you. Let me jump back on what you said about the importance of having big data to have AI algorithm. I would say that this depends on actually the number of parameters that we take into account. So for let's say simple algorithms that don't take that many parameters, so dosage, AMH, BMI, for example, you don't need that many cycles to take into account to have good accuracy in predicting the number of sites. For other types of algorithms, like the one you mentioned in the end, taking into account the development of the embryos. So you mentioned time lapse. This can be input about like the development times of the embryo into different phases, but you can also have actually the whole video of development. So the time lapse video of the development. This is actually for the algorithms, millions of parameters to take into account. And for this, that means that we need actually millions of samples and even more to have good quality data. The reason why this kind of algorithm is currently working in production in different systems is because we managed, I think, in my opinion, much more to share this data and to standardize it. Because one video of embryo in one clinic is going to be the same in another clinic. And so you can combine the two and actually have an algorithm working on this data, on this good quality data, which is not exactly the case for the rest of the data on the stimulation part. And as I was saying, we're trying to get there. Another thing that you said that was super interesting is that we don't have a one fits all strategy. I think it's going to be super important also to combine the data, so the common knowledge of all clinics, of all countries, but also to screw it with the data and with the methodology of your own clinic. And this is a parameter that needs to be taken into account if you want your algorithms to work well, is to adapt it to your practice and not take general models only.
I totally agree. So there is a lot of work to do, and I think that what is incredible is the velocity, how these kind of approaches are growing fast. And so I realized that until 2, 3 years ago, yes, we hypothesized. We had some examples of algorithm machine learning, but it was incredible the way they grew in the last time. So we know that science as a sort of a critical point where the growth became very fast. And I think that what you say, that if we have relevant number information from many centers, quality information, it will be incredible the way we will predict and to have integrity for improving our clinical practice. But if you had the magic wand, what you could realize in the next 2 years for improving artificial intelligence in reproductive medicine?
I would say I would put all known data, all known cycles, all clinics around the world together to actually make progress in our knowledge of understanding what works and what doesn't in fertility treatment. I would say that would be the main part currently, and there is a reason for this. All hospitals, clinics, in healthcare industry in general are really reluctant to share data because they know that there is a lot of value in it, and there is a question also of winner takes all. So if I had a magic one, I would change this and have the research make a massive jump thanks to sharing all the data that we know about patients. I need to specify something, of course, keeping the privacy and the integrity of the patients. So when I say that, of course, I talk about anonymous data and metrics and KPIs about cycles, but not actual sensitive patient data.
Yes, you touched a very relevant point I didn't mention because it's very crucial aspect, which is the crucial not only of privacy, because this is something that will be managed, but the problem is that sometimes, or in the vast majority of situations, the researchers are quite jealous of their data. So I have an idea. I want to test this idea. I want to analyze my data. I want to provide as first an information to comment. So I think it's part of this kind of adrenaline. It's very important for researchers. So the thinking that I put all the observation in a big pool where I can even be anonymous. I can contribute to humanity development and to science, but I run the risk to be a small part of a very large process. So it's very difficult. And I think that this is a crucial point that is not so often discussed. So what is the position if you are part of a huge research program in big data analysis? How can we manage the rule of single researchers, and what can be the relationship from central big data analysis and single research units contribute, and who is the owner of the data?
This is a very interesting topic. A lot of researchers are looking at this at the moment about the contributivity of the data in specific models, about also secure ways of sharing the data and of keeping trace of what contributed to what. To solve exactly this topic about the data I contributed or I put in participation to a huge model, what was the impact and who should benefit from it and how? Because of course there are questions behind. There is massive progress on this topic that I expect to be real live and common practice in the next 3 to 4 years, I would say.
I do hope.
Thanks a lot, Carlo. It was a super interesting discussion. And to all of our future participants, remember that you can join the program. So the MEDEA program, MAR Prediction Tools, on the 10th of May at 1 p.m. set time. And you can register on the MEDEA website and you will have a link in the podcast. Thanks a lot. And we hope to see you there.
Thank you, Jérôme. Thank you so much. I really appreciate it to discuss with you about this. And I'm sure that on the 10th of May, all these topics will be developed with a specific focus on reproductive medicine. So thank you. And thank to all of you for the time you spend with us.
To learn more about the upcoming CME program, Medical Assisted Reproduction Prediction Tools, KPIs, biological factors, RWE, and clinical decisions, please visit our website at medeaacademy.com/event/AI_MR 2024.